Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Ali, 55 years old, present with neck lump. Please take history, examine the patient, and address his concerns. Here you go.
Hello, I'm Dr. Naji, one of the doctor here today. Are you Mr. Ali, 55 years old?
Yes, doctor.
Mr. Ali, we are here today to discuss some issue about your health condition, and I want to examine you. It's okay with you?
Yes, okay, doctor. Go ahead.
Okay. Mr. Ali, you can tell me why you came today?
Yes, doctor. Actually, I have like swelling in my neck. Okay. This it appeared for me since 6 months ago, doctor.
Okay. Mr. Ali, you can show me the swelling, please.
Okay. Dr. Basim.
Okay, you told me this is started since 6 months.
Yes,
This
you
is
can
first
continue.
time,
Yeah.
Mr. Ali. Okay.
Yeah, it's shared
This is
already in the
first
chat
time.
box. Okay.
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 First time.
Yes, doctor. This is the first time.
Okay. Okay, Mr. Ali, you can tell me from day to day, it's increase or same?
Yes, doctor. It worse and progress with time. This.
Okay. There is any another swelling in the body like this?
I didn't sure, doctor. You can check it.
Okay. It's painful, mister. It's painful?
No, no, doctor.
Okay. What you feel increase it, Mr. Ali? What increase it?
I didn't notice anything increase it.
Okay. Anything worse it?
No, like what, doctor?
Any compression or any a drug or anything?
No.
Okay. Mr. Ali, you can tell me what's you have past medical history?
No, doctor. I didn't have
You
any.
not, okay,
Yeah.
you not have any chronic disease, diabetic hypertension?
Yes, doctor. Just I have diabetes, doctor. Since 5
Since,
years ago.
yes. What you use medication for diabetic? What you use medication for diabetic?
Yes, I'm taking metformin and glyceride.
Okay. Okay, you last blood test for the hemoglobin A1C, you know the reading?
Yes, I think 8.5 at that time.
Okay, okay, you follow with the clinic. You have any heart attack or stroke before?
No.
Okay, any pain in the leg when you're moving?
No.
Soreness in the leg or foot?
No, doctor.
Okay. What's about your weight, Mr. Ali? It's increased, decrease?
Yes, doctor. Really, I have weight loss. Okay. I think I'm lost like
How many
5 to
kg?
6. Yes, 5 to 6 in these 6 months.
Okay. There is any high temperature?
Yes, doctor.
Okay, you measure it?
When I measure, doctor, it seemed to be like 37.8.
Yes. More in the morning or in the day or in the night?
Not related to the time.
Okay.
Come and go.
Okay. There is a sweating,
No.
shivering.
Yes, doctor.
Okay. You can tell me, you contacted any sick patient recently?
Actually, doctor, yes, my father has diagnosed with tuberculosis before,
Since how
but
much
not
he's
recently.
diagnosed? Okay.
Yes, diagnosed before 1 year.
He received medication.
Yes, doctor.
He received the full course of the anti-TB.
I didn't sure regarding this.
Okay. You contact with him. You stay with him for how much, Mr. Ali? You living with
Doctor,
him?
Yes, I'm talking regarding my father, doctor. Yes.
Okay. You live with him now?
Yes, doctor.
And okay. Okay. He's okay now.
Yes, he's quite well.
Okay. I want to ask about headache. You have complain any headache?
No, doctor.
Loss of conscious.
No.
Okay. Any blurring of vision?
No, doctor.
Any neck pain with
No.
movement? Okay. Any chest pain?
No.
Racing heartbeat?
No, doctor.
Okay. You tolerated cough. You have cough.
Yes, doctor. I have cough.
This with the phlegm or dry cough?
Yes, with phlegm, doctor.
Okay. You can tell me what the color of the phlegm?
Yes, sometimes yellow, sometimes greenish.
Okay. You observe any blood with the phlegm?
No, doctor.
Okay. Okay. There is any tummy pain?
Yes,
Where exactly the tummy pain?
in all of my tummy, doctor.
If I give you score, how much you give this pain score from 0 to 10? From 1 to
3 to
10,
4.
1 mild and okay. What
Ah,
relieve this
3 to
pain,
4.
Mr. Ali? Okay.
Sometimes
Anything
I'm
increase the
trying to take
tummy pain?
painkiller.
Yes. Yes.
No,
Improve. Okay. Anything worsening this tummy pain?
no, doctor.
Okay. There is any loose motion or hard stool?
Yes, doctor, I have loose motion.
Okay. You since how much?
Yes, during this 6 months.
Okay. You can tell me more about this loose motion? It's watery or semi-solid?
Yes, watery, doctor.
Okay. There is any difficulty in the flush?
No,
Okay. Offensive odor?
no, I didn't see. So,
Black in color? Black in color?
no,
Okay. Any food increase this problem, like pasta,
no,
pizza, or something?
no, doctor.
Okay. You use any medication for this loose stool?
Try, doctor, but didn't help.
Okay. 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 There is any mouth sore,
No,
yellowish eye discoloration?
no,
Okay. Any difficulty in the swallowing?
no,
Okay. Any feeling sick?
no.
What about your appetite, Mr. Ali?
Yes, actually, doctor, my appetite become poor recently.
Okay. Okay. I'm sorry for that. Okay. What about water work?
Yes, it's fine.
Okay. No frothy?
No,
Okay. Mr. Ali, there is no skin rush?
No, doctor.
Joint pain?
No.
Okay, I want to examine you, Mr. Ali, please.
Okay. Yes, you can.
Okay, first I want to check vital sign for this patient. I want to check pulse and temperature.
Okay.
And I want to see
But
the face.
mm-hmm.
He is paler or jaundiced.
Vital chart
Okay, then I will.
normal. Okay. Temperature 38.
Yes.
Mm-hmm.
Okay, I go directly for the neck. I want to examine this swelling. It's tenderness.
Not
It's
tender.
firm or hard.
Yes, fair.
Okay, attached to the underlining to the skin.
Yes.
Okay, how much measurement of this swelling?
2 to 3.
Okay, no hotness, on this swelling. Any another swelling in the
No.
cervical area?
What?
Lymph node in the cervical area? Submandible,
No.
submandible, and the anterior and posterior cervical and the scapular? No lymph node.
Mm-hmm. No lymph node.
Okay, supraclavicle.
Yes, no.
Okay, I go for axilla and I will check if there is any another lymph node, if there is enlargement.
Okay. No.
And okay, after that I will go to the abdomen. I want to inspect it, inspection, and I do superficial palpation and deep palpation. There is any organomegaly or tenderness?
No.
Okay. Okay. Auscultation, there is any abnormal sound?
In
Splenomegaly,
the abdomen?
hepatomegaly,
No.
splenomegaly. No
No.
hepatomegaly. Okay. Lower limb edema.
Negative.
Okay. I want to check hand. There is any paler, palmar erythema, clubbing, or anything?
The lesion is pillar. No clubbing. No
Okay.
palmarism.
Yes, I want to examine the chest.
Okay.
Auscultation. Any abnormality in the auscultation, especially in the apical area?
Not in apical area. There is a bronchial breathing in the
Yes.
middle of middle of the chest, bilaterally.
No. Okay. No wheezing.
Noise.
Okay, Mr. Ali, still there is time. Mr. Ali, what you do for living?
Yes, doctor. Actually, I am businessman.
Yes.
Mm-hmm.
Okay. This disease affect you, Mr. Ali? Affect your life and activity, daily activity?
Sure, doctor. Yes, it impacting more, doctor.
Okay, Mr. Ali, sorry, I want to ask you some personal question.
Mm-hmm.
Okay. You have any regular partner?
Yes, I'm married, doctor.
2 minutes left.
And what's about you have unsafe sex, Mr. Ali?
Actually, yes, doctor. Sometimes when I'm going to travel because of my job, yes, sometimes.
Okay. You have any blood transfusion before?
No,
Okay. Any tattooing during traveling or
no, doctor.
okay, dressing?
Mm-hmm. No,
Okay. Okay. Smoking? You are smoking?
no, doctor.
Okay. Drink alcohol?
No.
Okay. Mr. Ali, what's your concern?
Yes, doctor. What I have, doctor? Why this lump got for me?
Okay. Okay, Mr. Ali. After I take information and after I examine you, I have many thing I thinking about it, but most probably this is maybe bug infection, Mr. Ali. Okay. Sorry, because you contact with your father, your father, and he's known of the TB, and I don't know about if he take complete course of the anti-TB or no. This is one of the possibility. And I'm sorry, I think also about HIV, okay, because you have unsafe sex, Mr. Ali. For that, I need to do some blood work and I need to do imaging. And we maybe need to take sample from this swelling. After that, we will discuss with the group of the doctor and I will sit with you and discuss the result of the blood work. It's okay with you, Mr. Ali?
Okay, doctor. Okay.
Any another
Doctor,
concern?
Yes, any management, doctor. My condition could be curable.
Sorry, what you said?
Yes, it is treatable, doctor. My condition could be treatable.
Yes, Mr. Ali. Now there is many medication, and we can control. This is controllable. Yes, we can give medication, and we follow with you. It's okay.
Okay, doctor.
Okay. Any another concern?
No, thank you.
Okay, thank you.
Examiner questions. Dr. Sarah, please.
Yes, present your case.
55 years old, a known case of diabetic since 5 years, and the regular medication, no macrovascular complication of the diabetic. He working like businessman, and he came with the history of the neck lump, I think in the posterior cervical lymph node enlargement since 6 months, not tender, progressive in the course. There is a history of the fever, weight loss, and loss of appetite. Contact with the TB patient. We not know the detail about his treatment, if he treated, complete the course of the TB or no. And also he is risky for HIV because he have unsafe sex. By examination, I find the patient febrile, he's pale, and there is only lymph node in the neck, and no another lymph node or no organomegaly. There is a mid-zone cryptation in the chest. Yes.
Okay, so what is your diagnosis and your differential diagnosis?
First diagnosis, I put TB. Second, HIV. I think about lymphoproliferative disease, but I'm not find any another lymph node enlargement. Maybe brucella, but I forget to ask the patient about the contact with the animal or something like that.
Okay.
Yes.
So what is your workup for this patient?
I need to admit this patient and I need to put him in a bedside room if he have TB. And I need to start, I will need to do blood work for the patient. I need to do CBC, chemistry. I want to renal function test, liver function test, and I need to do ESRD, reactive protein. And we need to do for him and test for the TB. And I need to take from him sputum for acid-fast bacilli for culture and sensitivity, and I need to do the HIV serology. I need to do also maybe I need to do chest X-ray also. Maybe I need to also high resolution CT. Yes, and ultrasound abdomen, and yes, ultrasound because we complain generalized abdominal pain. Sputum, blood culture, sputum, full blood count. Maybe I need to take sample from this fine needle aspiration from this lymph node.
Okay, well.
Yes.
Okay, doctor. So what is your treatment?
Depending on the cause, if this patient have TB, I need to put him in the isolation, and I start for him the anti-TB regimen for the patient, and will follow with him with the blood sputum culture. Okay. If HIV, we can start for him medication also for HIV. I need to do for him also CD4 count for the patient. And if there
Okay.
is HIV, I need to start for him the medication. Yes.
Any chance, any another investigation for HIV you want to do for this patient?
I need to do stool analysis. Maybe he has cytomegaloviral infection. I need to do ultrasound abdomen. Maybe we need also CT, a serology for HIV, and CD4 count.
Okay, okay, doctor. So you need to admit this patient or not?
Yes, I will admit him because I think first about TB also. Yeah, for that I need to isolated him first. Yes.
Okay. So did you check for sign of dehydration for this patient?
No. No.
Did you ask regarding the dizziness with postural drop?
No. No.
Okay. Yes, also didn't ask regarding the family history. Because this patient also, apart from tuberculosis, he has family history of bowel cancer. Okay.
Yes. Yes, I forget. Yes.
Okay. طيب, okay, thank you.
Okay, still 30 seconds. I will ask her one question. Dr. Al-Huda, what the diagnosis exactly? What you call his condition?
This patient,
Yes.
miliary TB, doctor. You mean that?
Why miliary?
Because he has abdominal pain, chest, and there is lymph node. I
Okay.
think about miliary.
Okay, since he's presenting with lump in the neck, what you call it? If only the lump.
Sorry, wallah, I'm not understand your question, doctor.
If he presented to you with a lump in the neck, lymph node, I mean, what you call
Okay.
it?
Adenitis,
Lymph node.
TB adenitis, you mean?
Lymphadenitis.
Reactive lymphomas.
Lymphadenitis. Okay. That's enough now. Dr. Sarah will comment, then I will comment.
Yes, she did well, but apart from not organized in the history taking, that is why you miss the family history and the drug also. Didn't ask regarding the recreational medicine. Okay, and travel history is the most important for this. Okay. Yes, HIV risk factor. You are asking about it, but late. Okay, and this in the history. In the examinations, also, yes, you are examining the lymph node. Okay, the good, and also the abdomen and the chest. Okay, your examination perfect. Regarding the differential diagnosis for this patient, you need to put first AIDS. Okay, because this patient has multiple complications of HIV. Okay.
Yes.
And also tuberculosis can differential and can also
Yes.
put metastasis from the colon cancer, because also he has the weight loss and diarrhea for a long time and has family history. It might be mets to the lung. And also lymphoma in the bottom of the list. Okay.
Okay.
Regarding investigations, yes, you mentioned it. Apart from yes, fine needle aspiration, you mentioned it. An excisional biopsy, HIV all screening, ELISA, B24, okay, and viral load also, hepatitis B, hepatitis C.
Oh, yes.
Yes, for the chest X-ray, sputum analysis, tuberculosis, sputum culture, bronchoalveolar lavage. For this patient, it's important. Okay, high resolution CT, as you mentioned. For loose motion diarrhea, just you need to mention stool analysis, culture for cryptosporidium for these patients, and also sometimes may need to do colonoscopy to check if there is any cancer. Okay.
Okay. Okay.
Yes, regarding the management, yes, first we need to admit these patients, rehydrations, electrolyte corrections, if there is any electrolyte loss, like potassium in these patients and other sodium. Okay. We will start antiretroviral, and if there's any tuberculosis, we start antituberculosis. But the differential in the chest or the lung problem, it might be due to opportunistic infection in the HIV patient or tuberculosis, second differential. Okay. Opportunistic like pneumocystis jirovecii pneumonia. And also, as you mentioned, cytomegalovirus for the gut problem, diarrhea. Okay.
Okay. Okay.
That is all from our side. Dr. Basim?
Yes, I will ask you, Dr. Sarah, first. If you have positive HIV and TB, which one you will treat first?
Yes, I will treat tuberculosis first. And after that, we can start treatment for HIV.
Why choose to treat the TB first?
Yes, to avoid the immune reconstitution syndrome.
Yes. Okay. I will ask Dr. Al-Huda now. Why you isolate the patient?
TB, doctor, because I
Okay.
put
When?
first
Okay.
diagnosis.
The next question. When you isolate TB patient?
Pulmonary TB. Pulmonary TB we isolate.
Any patient with pulmonary TB, you will isolate him, or you should do test to confirm something. Then you can isolate based on it, right?
Uh,
What is the test you have to do before isolating a TB patient?
Mantox test.
No, Mantox to confirm is he latent or
A sputum, doctor. Sputum.
yes. What type of investigation in the sputum? Yes, it's sputum. What type?
Acid fast bacilli.
Exactly.
دي
Yes, that's it. Any acid fast bacilli in the sputum, you have to isolate the patient for 2 weeks starting anti-TB. But if he is having negative AFP, you can start treatment only without isolating him. Okay? It's not infection.
yes, Dr. Bassel.
Clear? So whenever you are mentioning isolation, you should have a reason for isolation. The isolation is not easy thing or easy decision. I should have something important or positive or strong need to be isolated. And there is two types of isolation or more. But for the TB, what the type of isolation?
Negative pressure.
Exactly. Okay. If you suspect a cancer patient, what type of isolation you will do?
Cancer patient.
Yes, cancer patient started on chemotherapy. Lymphoma patient on chemotherapy. What the type of isolation?
I don't have idea really.
any immunosuppressed patient or immunocompromised patient, and he has neutropenia, what type of isolation you put?
I don't know really والله دكتور.
Okay, it's positive pressure isolation. The opposite of negative pressure. Okay, so the
Okay.
patient is at risk to have infection, but TB patient or to catch infection. TB patient, you are afraid to spread the infection,
Yes.
right? So it's the opposite. Okay, well done as in general, but as Dr. Sarah said, whenever you start to ask questions or group of questions, try to cover all together. Don't jump to another system unless you finish the first or yes, the system you started. For example, the constitutional, you ask about this sweat and temperature and the weight, but you didn't ask about appetite. What it can
Okay.
signify if you have positive all constitutional symptoms. What the importance of this?
TB, cancer.
Yes, so
Think
I
about
confirm this
cancer.
patient is having sinister symptoms and he's having something serious, either cancer or infection. And not only infection, serious infection, HIV, TB in this scenario, even AIDS, as Dr. Sarah mentioned. So
Okay.
three of your differential should be the three alarming or serious cancer or infection. That's why the case here was about TB, HIV, and cancer. Okay.
Okay.
The next system which you ask from here and there was the social. I think you missed the family history because you didn't, or you ask about travel without asking about family. I prefer to ask all these as a group of questions.
Yes, doctor.
Okay, so this is another social history you have to ask and to take it together. Hold please 1 second. Okay, sorry. Uh, Back to the history. The systemic review, I think you asked the old question. The tummy pain, you already also analyze it well. And you know that there is something in the GI, gastroenteritis or whatever the affected or the condition might be picked up from these questions. Okay, it's clear now,
Okay.
right? I think as an analysis of the lump itself, you took some time, 2 or more minutes to analyze it. Is it movable or mobile? And the firm, the consistency. You have to ask about previous. Sometimes the patient will have on and off. He has it before or he had it before and disappeared and come again. So you can consider something like infection on and off according to the immune condition of the patient. I think the case otherwise clear as TB or HIV and cancer. AIDS, you have to put it on the top. You can ask about, as you said, about contact with animal for brucellosis. It's one also of the infectious infections that it comes as differential, particularly in endemic area or a particular job. Otherwise,
Okay.
the case was clear after you got contact with sick patient, diagnosed as TB. The good thing you analyze the TB of the father. Did he take the medication? For how long? How is he now? You have to ask these questions. Yes, you spend some time as well for the diabetes and the diabetic complication, which also waste some time. That's why you didn't have the good time to examine the patient. I believe
Okay.
if there is something related to the diabetes directly, you can analyze the whole diabetes. Otherwise, try to make the systemic review, and during taking or asking about the systemic review, you can ask about every complication during the system review. For example, if you want to ask about CNS as a system analysis of the systemic review, it started by the head and the CNS. You can ask about the headache, you can ask about any change of vision, any blurring of vision, any pins and needles or weakness. Pins and needles in this time would be related not only to the systemic review, would be related to what?
To diabetic, yes.
Exactly. So you mean I'm asking about diabetic neuropathy. I can add to these
Okay.
questions any history of stroke or mini stroke. So I showed the examiner that I asked about the CNS and I asked about the complication in the CNS related to the diabetes or poorly controlled diabetes. The same while asking the genitourinary. You have any change of your water work? And I can add one more question, any frothiness, any change of the amount, increase of the amount. So I'm asking about the genitourinary as a system and the relevant or the related diabetic complication in the kidney, which is nephropathy. The same for ischemic heart disease or coronary heart disease. Do you ever have chest pain, awareness of heartbeat, or heart attack? So I added and I merge the complication of diabetes with the system review without taking long to analyze the diabetic complication. Why? Because this patient is not having something directly related to the diabetes. Maybe it's indirectly related if the patient immunocompromised, but in this condition, we are talking about some other serious infection, which is TB or lymphadenitis or lymphoma or cancer or HIV. So I want to analyze it, yes, the diabetes, but in a very rapid manner. You can add to them the hemoglobin A1C separately and or while you are taking the medical history, if you ask about the diabetes, and you can add also any hypoglycemic attack just to be sure that you are covering the welfare. The last thing, don't forget the surgical option, the surgical history, any procedure, because this patient might have procedure which had transferred to him or transmit to him the infection. Dental procedure, for example, in the past, and he had after that HIV or the hepatitis. Okay, allergic and herbal, you can add
Oh,
it.
okay.
And as Dr. Sarah said, whenever you suspect HIV in any patient in PACES, you have to ask all HIV questions. Any recreational drugs, any sharing needles, tattooing, piercing, blood transfusion. Plus, the sexual history. You have a stable partner? Yes. Sorry for this question. Do you have any casual relationships? Okay. If he said yes, I have,
Oh,
you have to know when exactly the casual relationships, and you have to specify a question, was it protected? Okay. Don't ask directly, do you have unprotected sex? You have to know first if because he will feel embarrassed and weird question why you ask directly. So you can start first as preparation. Do you have stable partner? Yes, doctor. Sorry for this question. You have casual relationships? If he denied, don't ask anymore. If he said no, I don't have any casual relations, so you don't ask him, do you have unprotected sex? Because he doesn't have. He has his stable partner. You cannot pretend that if he has stable partner, he should or he had TB or sorry HIV from outside. Okay, unless he said he has history or his wife had HIV, so you can give the HIV as a history or as a differential from his wife. Otherwise, don't pretend that he has HIV and he got it from unprotected sex. You have to know first by the questioning. Is it clear?
clear. Dr. Bassem, when I want to
Mm.
examine the, sorry, when I want to explain the the diagnosis of HIV for the patient. What I said he have HIV. I told him like
Yes.
this.
Have you ever heard about it? Whenever you are talking about something common and famous, everyone in the world knows about the HIV, right? If he said, no, doctor, I
Yes.
didn't hear, you can explain the abbreviation. Okay, but if
Okay.
most of them, even in the bases in UK, they are asking about HIV as a question. And do you think that you have HIV? Because it's common there, and a lot of transmitted sexually transmitted disease through or HIV is transmitted through the sex. That's why it's easy and it's a common question. Even in the past tests, they are asking, do you have HIV? Yes, doctor, or no? Then you can proceed further. If you are in overseas, you can ask. It's
Okay, doctor.
maybe it could be HIV. Have you ever heard about it? If he told you, or if he tell you, and then never, doctor, I heard about it. Now you can explain about the virus and the AIDS. Okay, and by the way, sometimes they ask, what the difference, doctor, between HIV and AIDS? Do you know the difference, Doctor Huda? If the surrogate ask you, doctor, is it AIDS? You said you will say, for example, in this scenario, possibly could be AIDS, but some other scenarios, he will tell you, doctor, is it AIDS? Not in this scenario, you will tell him, no, it's unlikely to be AIDS. What the difference between AIDS in this scenario and another scenario? You can tell him, no, it's not AIDS. Why this scenario? In brackets, why we said in this scenario this patient is having AIDS or possibly he has AIDS. What do you think the reason of diagnosing this patient with possibly with AIDS? Dr. Al-Huda? Hello?
Yes, sorry, Dr. Bassem.
So what the answer? Do you know what the difference between HIV and AIDS?
Yes, HIV only in the lab, but AIDS there is opportunistic infection and symptom.
Yeah, this is the answer. Yes, whenever you have opportunistic infection or more, this is the time to mention this patient is having AIDS.
Sorry, because the net disconnected for
No,
that I
it's
don't
okay.
really
No, no,
hear.
it's okay. So this is the answer. And by the way, whenever you are testing for HIV, you have to do the all test. So when you suspect particularly the AIDS, you have to do the advanced test for AIDS. As you said, CD4 count, the viral load, as well as ELISA for antibodies. But if you have patients just or recently suspected to have HIV, you can start with P24 antigen, right? And you can do
Yes,
also ELISA just to know his baseline. He might have it before.
okay.
PCR and viral load, if you have already diagnosed patient with TB, sorry, with HIV. So you want to know how much the virus in his blood. But for antibodies, for the antigen, for newly transmitted or just have a needle stick or he just have sexual intercourse with the HIV patient or needle sharing or any risk factor that can transmit the virus. Clear for all? And you, Dr. Huda?
Yes, yes, doctor.
Okay. You have any question?
Thank you.
Dr. Sarah, any question?
Yes, I'm ready just to start. No
Okay,
question.
no question. What is the scenario? She posted Dr. Al-Huda. Okay,
Yes.
65 years, Mr. Salim. Known case of diabetes, end-stage disease, old stroke, came with fits. Please take history from his son, Mr. Ahmed. Okay. Yeah, here you can.
Okay. Hello,
Hello.
I'm Dr. Abdul Karim. I'm one of the doctors covering the service today. May I confirm that you are Mr. Ahmed, a son of Mr. Salim, 65 years old?
Yes.
Mr. Ahmed, are you the next of kin of Mr. Salim?
Yes.
Okay, so we are here to talk regarding the health condition of your father. After that, I want to examine him, or we can address your concern. Is it okay with you?
Yes, doctor.
Okay, could you tell me what brought your father here today?
Okay, my father is now in case of diabetic and end-stage renal disease. In the
Mm-hmm,
morning, he did his schedule of dialysis. After that, when
mm-hmm.
he came back to the home, he's unwell. Uh, he said he's feel tired. Sudden he developed this shaking of his body.
Okay, I'm sorry for that. This is the first time to happen for your father.
Yes, yes, doctor. Yes.
Is there any trauma before this?
No, no, doctor. No.
Okay, regarding his kidney problem, since when?
Yes.
You.
Doctor, since long time he has chronic kidney disease, but they
Mm-hmm.
start for him dialysis recently. Yes.
Okay, so how many sessions per week?
3 per week.
Mm-hmm, mm-hmm. Okay, regarding this session, did you check his blood sugar at that time before this?
Uh, during the shaking of the body, yes, I check, doctor. It's okay.
Before. Mm-hmm.
Yes.
Okay, so is there any abnormal sensation or abnormal
No,
smelling
no,
before this?
no, no. He said he feel headache and
Mm-hmm.
he's feel tired, headache and
Mm-hmm.
feel tired. He feels sick. Sudden he drop and he have this shaking of his
Mm-hmm.
body.
Okay. Any hunger pain associated with handshaking and sweating before this happen for him?
No, 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 doctor, no.
Did he lose his consciousness at that time?
Yes, doctor, and he's rolling
Mm-hmm.
his eye up. Yes, yes, doctor.
Okay. This shakiness in all of his body or in one
Yes.
part in?
No, 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 in all the body, yes.
Did he lose the control of water work or back passage at that time?
Yes, he with his self, yes.
Mm-hmm. Did bite his tongue?
No, no,
Any injury?
no, 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 no.
Mm-hmm. Okay. You check your blood sugar during this?
Yes, doctor, the blood sugar, it was okay during the attack,
Oh,
yes.
okay. How this terminated? And since and
Uh,
for how long it continue?
it's continue maybe for 6 minutes. Then he
Mm-hmm.
become quiet. After that, I feel he's not well.
Mm-hmm.
He's drowsy. For that, I bring him directly to the hospital.
Okay. So if there is any weakness after this?
I am not examine him. Sorry, I'm not check him, doctor. I bring him directly after because
Mm-hmm.
he's not good. I bring him directly to the hospital.
Okay, that's right. Okay, so how this episode terminated spontaneously, or did your father eat any sugary substance?
No, no, no. Spontaneously.
Mm-hmm. Okay. Is there any weakness before or now?
Um, no,
Mm-hmm.
he before doctor. He have one time he have dizziness and that's time the
Mm.
doctor told us he has mini stroke. That's time, but my father he's okay.
Minister.
Yes, before yes.
Okay. Okay. Any vision problem?
No, he's okay.
Any unsteadiness
No,
before?
no, no.
Mm-hmm.
When he come back from the dialysis, yes, he's not
Mm-hmm.
well, and I feel he's not steady, unsteady.
Okay. Okay. Yes, if there is any neck stiffness.
No,
Okay. Any confusion before or now?
no, doctor, no,
Okay. If there is any high body temperature.
no,
Mm-hmm.
no,
Okay. If
no,
there is any. Okay. Is there any sensations in his hand or in feet?
No,
Abnormal
doctor.
sensation, numbness, or
No,
around
doctor.
his mouth? Mm-hmm.
No. He
Okay.
not. Yes.
Any spasm in his hand or feet before this?
No, I'm not observed.
Okay. Any weight change?
Wait.
Yes.
No, doctor. No.
Any lump or bump in his body?
No, doctor.
Mm-hmm. Any tiredness?
No. When his start the kidney problem,
Mm-hmm.
he was tiredness, but now the doctor, when he schedule for him the dialysis, I think
Mm-hmm.
no, he's يعني still tired, but with the doctor told us with the dialysis he will improve.
Okay. Okay. Any sweating?
No, doctor.
Mm-hmm. Anyone? You comment that your father become more pale?
No, doctor.
Mm-hmm. Okay.
Because
Any
he
medical
has,
background?
sorry, doctor, he has
Mm-hmm.
anemia before. The doctor told us he has
Mm-hmm.
anemia because he has a kidney problem. For that, they
Mm-hmm.
give him medication.
Okay. So is there any medical background apart from this mini stroke and
No,
kidney
he's
problem?
diabetic. His diabetes is 15 years, doctor, only. And in the stage
Okay.
renal disease now, yes.
What about his diabetes, high blood sugar? Control where?
Yes, doctor, yes. We try,
Mm-hmm.
he use his medication. He now use insulin.
Okay.
He follow with the doctor in the clinic. We follow before 2 months.
Mm-hmm. Mm-hmm. Okay. Okay. What regarding the last accumulated blood sugar reading?
Yes, doctor. It was before 2 months. It was 7.5.
Mm-hmm. Okay. So could you show me his medication list, please?
Yes, doctor. He use amylor, lisinopril, and
Mm-hmm.
vitamin D and calcium
Mm-hmm. Okay.
and insulin.
I'm sorry for asking this question. In education medicine,
No, doctor.
does your father he has any dizziness when he changed your position from sitting to standing?
No, doctor. He has dizziness today only. This is first time, yes.
Okay. Okay. So
Yeah.
is there any change in the waterwork regarding the amount, color, frequency, and frothiness?
No, doctor. No, he not have water work now. It's
Okay.
little amount
Uh,
now. Yes.
Okay. Any chest pain,
No,
any shortness of breath,
no, doctor.
any cough,
No, doctor.
any swelling in his leg?
No, doctor.
Okay. So any change in the bowel habit?
No, no, doctor.
Mhm. Okay. Any joint pain?
No.
Any skin rash? Now or before?
No, doctor.
Okay. Is there any family history of thyroid conditions?
No, my grandfather, he has diabetic and he's passed away.
I'm sorry for that. Okay. Is
Thank
there any family history of brain or cancer in the brain or
No, doctor. No.
conditions called epilepsy? Mm-hmm.
No, doctor. No.
Okay. Uh, so um. Yes. Okay. So what your father he doing for living?
My father, he's retired.
Mm-hmm. Okay. Does your father need any kind of help from us?
No, thank you, doctor. No, thank you.
Mm-hmm. Does your father smoke?
No, doctor.
Does your father drink alcohol, much alcohol?
Uh, yes, he take 1 or 2 cup per week.
Okay. Okay, per week. Okay. So does your father drive?
Yes.
So we need to sit with him and we need to advise him regarding to stop driving until further assessment. Is that okay?
Okay, I will try with him. Yes, doctor.
Okay. So may I examine your father now?
Yes.
Okay, I need the general look of the patients, including yes, the vital chart, blood pressure,
Uh,
temperature.
blood pressure 150 over 80.
Okay, beside blood sugar test.
Okay,
Mm-hmm. Okay,
120. Yes.
okay. I'm going to check to examine the yes to check for potential drift.
No, normal.
Okay, I'm going to check for sign of dehydration for this patient.
No, no dehydration.
Okay. Yes. Okay. I'm going to examine the eye if there's any pallor, any jaundice.
His pillar, mild pillar, yes.
Mm-hmm.
No jaundice.
Okay.
No jaundice.
Okay. Okay. Going also to check the facial muscles, facial nerve.
No, no weakness. No, no asymmetry in the face.
Now the conscious level, he's conscious now, your father. He's
No, he's
aware regarding.
drowsy. He is
Okay.
drowsy. Yes.
So I need to check to do mini mental status score for these patients and to do GCS also. I would like to yes to aware if he aware or oriented regarding the time, place, person now.
He's aware, but he's dizzy. Dizzy. Yes.
Okay, okay. So I'm going to check for neck stiffness for this patient.
No neck stiffness.
Okay. Also cerebellum examination. This diadokinesia or anyone.
We cannot do it because he's dizzy. He cannot do well.
He can. Okay. Okay. So I'm going to examine the abdomen.
Abdomen,
If there's
soft
any,
lax.
yes, yes, okay. No scar. The
No, no,
fistula.
no, doctor.
Okay. Any infection in the fistula for these patients.
And no fistula, doctor. He has vermicath in the neck.
Okay. Okay. So
Yes.
any infection or any discharge or
No, no, doctor.
mm-hmm. Okay.
No.
So I'm going to examine the lower limb, plantar reflexes, and to check the power.
Plantar reflex upgoing.
Mm-hmm.
Power normal. Power normal.
Okay.
No weakness.
Okay.
Yes.
Okay. So yes, just I'm going to auscultate the chest and
Uh,
the.
chest clear.
Mm-hmm. Okay. So may I know what is your concern now?
Yes, doctor. My father, he has epilepsy.
Mm-hmm. Um. Your concern is valid. Actually, after I'm asking you and after examining your father have been trouble with this shakiness of his body, most likely related to condition which you called disequilibrium syndrome. This in which there is a disturbance in some salt in his body related to dialysis. After dialysis, this has happened, and when yes, so. And also, what we are going to do now for your father, we are going to admit him, and we are going to run for him some blood tests and some scanning, and
Yeah.
we need to do yes, a special test to confirm our diagnosis, and we need to keep him in good follow up with a group of specialists, which include the nerve doctor and the kidney doctor. Okay,
Yes.
we need to correct his conditions. It might need to give him medication, fluids through the needles. Regarding the epilepsy, epilepsy is one of our possibilities, but we need to rule out also. Okay,
2 minutes
Yes.
left.
so
Okay, doctor, I want to ask you, we must stop now the dialysis because you say this is related for dialysis.
yes, yes, I help share your concern. And now, first we need to do further test to confirm if this condition or the cause of condition or not. After that, the kidney doctor and the nerve doctor, they will sit together and will decide the better options for him. But
Okay, thank
it's
you.
likely yet to resume the dialysis, but in the better way to avoid like such complication to happen.
Okay, thank you, doctor. Thank you.
Okay, thank you.
Yes.
You want to start examiner?
Okay. What your diagnosis, doctor?
Yes, my diagnosis, yes, in these patients, disequilibrium syndrome, electrolyte disturbance, and also I will put might be uremic encephalopathy or infections like meningitis, encephalitis, but again, is that no symptom or sign going
Okay.
with it. And also stroke,
Okay.
I will put.
Okay. What the investigation you will do for the patient?
Dr.
Yes,
Huda, excuse me, sorry. Let her
Yes.
present the case first.
Sorry. Okay. Sorry. Present the case, Dr. Sarah.
okay, so Mr. Salim, 65 years old, presented with fitness, who is in the stage renal disease. This seizure comes after dialysis, and also he is non-diabetes. Okay, and he has many stroke before. Yes, regarding he's now drowsy, not oriented well. Apart from that, I could not appreciate any other finding in our examination. Okay.
Okay. Okay.
Okay.
Dr. Sarah. Okay.
Yes.
You said that yes, management of this
Yes.
patient.
No,
Yes.
differential. Dr. Huda, present the case, what's your differential, how to investigate, how to manage. Okay, in this way.
Because she already said
Okay. Yeah. Much.
differential
Yes. Yeah.
diagnosis. For that, I want to repeat. Okay. What's
She
your
said
diagnosis?
only disequilibrium
Yes.
syndrome. She didn't mention other
No, she
differential.
said meningitis and
Yeah. I
okay.
mentioned. Yeah.
No,
Electrolyte
Okay,
no
disturbance,
problem.
hypoglycemia. Okay.
okay.
Infection.
Okay.
Yeah.
Okay,
Okay,
Dr.
go ahead
Stroke.
to
Asad,
them.
what's your diagnosis? Okay.
Okay. Also, regarding the investigation for this patient, general investigations, I will do a full blood count and inflammatory markers is R and CRP, and also electrolytes. The most important electrolyte in the patient: serum calcium, serum potassium, serum sodium, magnesium. Okay, and also renal function test. And other liver function test and specific investigations for this patient. Okay, I will do for this ECG. Okay, beside
Yes,
ECG
yes,
and yes, blood pressures and
yes.
hemoglobin A1C also, and I will do okay, yes, EEG for these
Okay.
patients. If yes, EEG
o-
also to
Okay.
exclude others.
Yes.
Mhm. Yes,
Okay.
and CT or MRI
Okay.
brain.
Okay. Finish my question.
Okay, still 1 minute and 40 seconds. So I will ask her some questions.
Okay.
Will you admit the patient?
What?
Will you admit the patient?
Yes, I mentioned to the patient. Yes, we need to admit him. Yes, we need to admit him.
Okay.
Mm.
What's the duration of dialysis for this patient? Since when?
Duration for this time, or you mean previous?
Yeah, the when he started the sessions of
Yes,
dialysis.
she mentioned recently. He mentioned recently.
Okay.
Recently start. Mm.
Okay. How this equilibrium syndrome happen? Do you know?
Because the patients after dialysis, he yes
Yeah,
complain of
after
these
dialysis.
fits.
Okay.
Yes, after dialysis.
Do you know the mechanism or the pathophysiology?
Yes, I think yes, there is a strong hemodialysis. I think like this.
But you
Remove
don't know the
urine.
details, right?
What?
The details.
The details?
Yes, I mean
Okay, yes, yes, because
yeah. Tell me
yes,
how it happened.
I think yes
Based on what you
بقول على عشان
mentioned.
هي yes, there is a rabbit fall in the urea
Exactly.
secretion through the, so the
Yeah.
patient develop cerebral edema and it can cause for him this
Due to osmotic pressure,
yes,
so
osmotic
yeah,
pressures
will be higher in the
mm,
brain, and the fluid will shift
to the brain.
into the brain, and it will lead to the cerebral edema. Patient will be either
Mm,
confused or even seizing.
yes.
Okay, so
Yes.
that's enough for me. I wanted to know how, and based on what you mentioned, the disequilibrium, you know already the difference and the rationale. Dr.
Mm,
Al-Huda will comment now, then I will comment.
Okay,
okay.
she's do very well. She asked about the most of the question. She analyzes the fates, but she not take full history about the dialysis because this patient, this is the first dialysis for him this week. For that, he has vermicath. He has not have any AV fistula.
Mm,
Okay, this is the first time for him to do dialysis. You must ask if the symptoms started when he was during dialysis or no, and how many hours he stay for dialysis. Okay, and sometimes you are right. This the diagnosis disequilibrium syndrome. This is happening most in the newly started dialysis or patient to chronic dialysis, but he missed many time the dialysis and started again to do dialysis. More patient risky for this condition, that's extreme age, the young age and very old age, and any patient with the history of brain problem like this patient, like stroke or like that. The this equilibrium, the patient can came with the dizziness, headache, nausea, vomiting. Sometimes it can have fits and sometimes death. Sometimes the symptoms started during dialysis. The need to adjust into the dialysis, we need to start by the slow and gentle. And first time to do dialysis, we not need to more than 2 hours, and we can do in the next day also 2 hours, but gently and slow we remove that. And we need to put more, we increase the sodium in the dialyzed solution to prevent the osmotic problem for this patient. Some patient they ask to stop the dialysis. We not stop dialysis for the patient because this problem. We need only to uh, adjust the dialysis. Okay, for that the patient need admission and he
mm,
need admission, and we need to seen by the nephrologist to this proper management. You ask about the hypoglycemia during attack. Yes, because most patients of the end-stage renal disease or chronic kidney disease, they have decreased the secretion of the insulin. For that, the patient maybe develop hypoglycemia, and maybe they have seizure. And also, you ask about electrolyte imbalance. Most of them, it's hypocalcemia can also cause the convulsion. And also, last thing about blood pressure during dialysis, how much he's reading about blood pressure because he used medication. Maybe the patient has maybe high blood pressure and maybe he have um, hemorrhage. Okay. Last thing, the dialysis model for the patient, we must ask. And you already you examine the line. We must examine the line. Maybe the patient has line sepsis only, but you do well. Thank you, Dr. Sarah.
Okay, thank you,
thank
Dr.
you,
Al-Huda.
Doctora. Thank you.
Yeah, thank you, Dr. Al-Huda. Nice case. And well done by Dr. Sarah. I will add just comments only. Yes, the analysis, that's why I asked you when this patient started dialysis. I think you didn't
Yes,
ask Dr. Sarah.
no, I asked just she tell me recently.
Yes,
And I
recently
asked
you
how
have to know
many, yes,
exactly.
how many session per weeks also. Yeah,
Yeah,
you
when
didn't
it
mention.
was when it was initiated, you have to know,
Mm,
because always or
yes.
mostly commonly it will happen or it happens after the first session. If they are aggressively
Mm,
removing the toxins,
mm,
the patient will have this complication. And as Dr. Al Huda said, sometimes they can add sodium, and in severe cases with severe seizure and neurological manifestation, they can even administer mannitol.
yes,
Okay,
Yes.
particularly
And the hypertonic saline
and the
also, yes.
hypertonic saline as well. Yes,
Yes.
hypertonic saline.
but with cautious, because he doesn't have urine output. You will just increase the osmolarity without diuresis. So be careful
Yes.
whenever you are giving, and should be treated under multidisciplinary team approach. The other thing here in
Yes.
this scenario, you should take care of the hypoglycemia, of course, we mentioned, and you check the blood sugar, but the hypocalcemia, you have to rule it out. However, the patient on vitamin D and calcium, but as you know, the calcium in the kidney patient, commonly they have hypocalcemia, right?
Mm.
So
I
these,
asked
Yes.
regarding the hypocalcemia symptom in the history,
yeah,
but in the
but you
examination
didn't
didn't check.
exactly. You have to offer
Yeah.
them Chivostic and
Yes.
Okay.
Toroslosine. Exactly.
Further sign, yes,
Yeah,
exactly.
you have to offer it, even you will not do it. This
Mm.
also one of the complication.
No, yeah.
Hyper hypercalcemia with vitamin D. You have to analyze the medication. You didn't ask commonly. Whenever you have medication, ask three questions. Since
Mm.
when this medication started? Are you compliant to this medication? Did you add or change any dose of this medication? When it
Mm-hmm.
started, are you compliant? Did you change any dose of this medication? Or did you add another medication to those medication? Why? Sometimes it might be related to a new medication just added. And you'll be unlucky if you didn't analyze since when this medicine started. Okay, so be careful whenever you have medication list, revise them, read them name by name, medication by medication, and ask grossly any medication added recently, any change of any dose of this medication, since when you are on this medication. Sometimes it might be at the same duration and the same onset of the complaint. So you will be lucky to catch the diagnosis from the medication list, and you will say it might be related to this drug or medication. Why? Because the onset similar to the onset of the complaint. Hypervitaminosis D, one of the common manifestation and so
Mm.
common complication. Some patient will take vitamin D without monitoring, and the patient will be in vitamin hypervitaminosis D along with hypercalcemia. Hypercalcemia as well can cause confusion and seizure. So be careful whenever you have medication. Try to analyze the all medication, not only one. Otherwise, as history taking, you did great. You analyze most of the questions related to this condition, and the hypoglycemia here is very important. Chronic kidney, chronic liver disease patient, most of them having possibly hypoglycemia, either because of the insulin secretion or the low intake, oral intake, low or loss of appetite, or even the metabolism of glucose, as in the chronic liver disease. So you have to know and to ask for any patient with fainting about his blood sugar. Did he check? And even if he regain, is it because of candy or sweetie food? So it might be the hypoglycemia as a differential, or it might be the case. So always ask about this. Did you check or anyone check your blood sugar to rule out the hypoglycemia? Okay. So these are the most relevant differential for this case. This equilibrium syndrome, hypoglycemia, and for me, I can say severe hypocalcemia. Okay.
Yes.
Any question or comment, Dr. Sarah and Dr. Al Huda?
No,
No,
thank
thank
you.
you.
Nice
Okay.
case, Doctor. Thank you.
Thank
Yes.
you for your Dr.
Don't forget as well to ask about any procedure and the permacath when exactly inserted. And
Yes.
while you are examining, ask for the fistula, the current mode, and the previous mode.
Mm-hmm.
Here in this scenario, the current mode is permacath.
Vermicast, yes.
Yeah, you might have patient with AV fistula just generated, and you have to examine it for Berui and thrill. If not, you can say it's just created by the vascular and it's not working or not functioning,
Yes.
right? Yes.
Yes.
Okay, I think it's clear now for all of us. Anyone with question? Plantar reflex was upgoing. Good question. So
No, not
you
going.
mentioned upgoing, yes. So it's not upgoing. It was
Sorry,
normal.
maybe by mistake. Sorry.
No worry. But good to pick up. I think Zoom user, yes, good to pick up it. I heard it also, and I was wondering why it's upgoing. Anything central? Okay. Any other question? Mannitol, yes, we mentioned already the mannitol in severe neurological symptoms. It might be administered along with hypertonic saline. Not both of them. You can give one of them because both of them are elements of osmolarity, the equation of osmolarity. Blood glucose, the sodium, and the urea. Mannitol is something artificial from outside that can raise the osmolarity. Any other question? Any missed point? Any suggestion?
Dr. Basim, I need to ask something regarding
Yes, Dr. Ruth.
regarding the differential diagnosis, because what I know that during dialysis session we need to give heparin as anticoagulant during the session. So I mean, in the investigation, we should first put yeah, one of the differential. I mean, the differential diagnosis of acute stroke or hemorrhagic stroke. We will put it in the differential. I mean, after post disequilibrium dialysis syndrome, or I mean, on the top of the list. I mean, the disequilibrium syndrome will be by exclusion, or we will
Yeah.
put it in the bottom of the list. This is my question.
Yes, they will give you a clue. As in this scenario, it was the first session for him in the life. And I think they can also give you a clue that it was longer than expected. Suppose the first session to be 2 hours, right? As you know, it will be the like the half efficiency of the regular dialysis. So you cannot. This will be the clue for you. The first session, and it would be half, or it will be longer than the supposed to be. So easily you can put this equivalent on the top. As any kidney patient, electrolyte disturbance is very common with them. Hyper calcemia, hypernatremia, hyperphosphatemia, and the also kalemia, hyperkalemia, the potassium. But potassium will not lead to seizure. So we have calcium or the sodium, hypernatremia or hyponatremia, phosphatemia as well. Okay, so for your differential, it's good to mention it, and it's I think something no one thought about it. Me even I didn't think about it, but it's considered as one of the differential. But once you have it, what do you think the reflexes and the conscious level of the patients if you have hemorrhage, Dr. Marwa?
Yes, it will be deteriorated, but also the patient.
Yes, exactly.
I mean, also the patient will be confused, even if this equilibrium syndrome. And in the practice, when we saw the patient like that, usually we will put the we will put the differential as one of the option of this equilibrium syndrome, but also it will be a little bit by exclusion. I
I
don't know
agree
if
with
you
you.
agree with me or no.
Yes,
I
yes,
mean,
I agree with you.
after exclusion of the stroke, and we will do urgent CT brain, and we will do the electrolyte and check everything. Then we will think of
Yes, I agree with you, but
post dialysis equilibrium syndrome.
as I mentioned to you, the first session or the
Yes,
newly,
yes, I know.
this is the
Yes,
clue. Yeah.
yes, I agree
I
with
Otherwise,
you.
yes.
mentioned stroke in the bottom of my differential actually.
Yeah, hemorrhagic
After
hemorrhagic type particularly. Why? Because there is heparin during the session. Yes, the patient is receiving. It might lead to the hemorrhage, but it will be for the frequent dialysis patient, not as the first session of dialysis. But you can put it as differential. Definitely, it's one of the
yes,
possible differential. Yes, plus the electrolyte, as I mentioned.
yes,
Easily, you can put hypoglycemia. Any chronic kidney patient, they are mostly maybe easily go to hypoglycemia. Why? Because of the insulin excretion and the kidney function. Sometimes of the most of them taking the insulin, and with the time the insulin dose will be lower. They went into hypoglycemia easily, and the hypoglycemia as well will lead to seizure and disturbed consciousness. So the easiest complication or differential you mention here is hypoglycemia, hypocalcemia as well, and you can add, as you mentioned, the hemorrhagic stroke. Anyway, you have to do CT brain to rule out any central cause. In this scenario, you might have cerebral edema.
Yes.
Add to your investigation serum osmolarity. Don't forget it. Okay. Thank you, Dr. Marwa. Nice comment and good suggestion. I think you are a nephrologist, right? So the nephrologists are aware about this complication. What about post-stroke seizure? Yes, we mentioned either stroke or ischemic or the hemorrhagic. Both of them, they might be in seizure as a secondary, but supposed to be major stroke, something large, sizable one. Okay. Yeah, thank you, Dr. Marwa. Anyone with question or suggestion? Dr. Saman? Sorry, missed the point. Why it can't be hypocalcemia? No, we said it can be hypocalcemia. It can be. Yeah, it can be. It's the third. I put it as the third differential after hypoglycemia and this equilibrium syndrome. Because most or all of the patient with chronic kidney disease, due to inactivation of vitamin D, they have hypocalcemia, right? So you can say, even with dialysis, by the way, any electrolyte, you can say electrolyte disturbance with dialysis. Because not usually the dialysis will normalize the electrolyte. Sometimes there is the mistake while putting the dialysate, adding some electrolytes, even the machine disturbance or troubleshooting. So maybe even with the dialysis, the electrolyte will be not well normalized. So either during or after the dialysis, patient having electrolyte disturbance. That's why they usually do post-dialysis chemistry, particularly the first days. With chronic dialysis, Dr. Al Ahmed, what is that? What with chronic dialysis you mean?
Yes, Dr. Basim. Assalamu alaikum. What
Alaikum
I mean,
salam.
hypocalcemia secondary, if you mean that is, it can happen only with chronic dialysis. It can happen with acute, with first session of dialysis. It can happen that the patient will develop hypocalcemia.
No, no, even with with chronic, they are mostly
No, what I meant,
hypocalcemic.
most with chronic patient, yes, it is understandable. The vitamin D, the
Exactly.
whatever
And
this,
with the
yes.
time,
But
they
even
might
with the
be,
acute or
with the time, they might
no,
be
no,
what?
what I meant
Hypo?
here, we can put we
Continue. Okay,
with the
continue your
time can
question.
be hypo, yeah. But what I meant, because this patient, they said this is his first session of dialysis. if
Yeah.
he can develop hypocalcemia in his first session of dialysis?
Yeah, why not? Because you just pass his blood through new machine and they are filtering. You don't know how the blood will tolerate the machine, so you might have it.
I don't know, but basis wise, I think so almost if they brought something like this, they will ask about the hypocalcemia as a chronic complication of the vitamin D and
Yes, I
low.
agree with you.
Mm,
By
mm.
the way, in the long term, most of these patients will have tertiary hypercalcemia, right?
Tertiary, yes, yes,
Yeah.
yes. Mm.
So initially they might be hypo, but with the time they will be or they might be hypercalcemic.
Tertiary hyperparathyroidism, yeah, yeah.
Yes, exactly. Tertiary hyperparathyroidism, and on the long term they will be hypercalcemic.
Mhm.
Okay,
Okay.
as a nephrology point of view, I cannot say or I cannot give you a clear cut off. Is it first dialysis or first session for the hypocalcemia itself? But usually we see those patients with hypocalcemia. I don't know if with dialysis they will be hypo as a significant hypo, or maybe something else might lead to the severe hypo. I'm not sure actually. If we have any nephrologists with us in this group now, they can give us a lot of details if they have any nephrologist with us can give us more rationale about the hypocalcemia particularly. Okay, basis wise, hypocalcemia, it can come as, let's review it, okay, for refreshment. What are the possible common cause of hypocalcemia in patients? Symptomatic, the tetany, I mean, in brackets. Anyone? Anyone would answer? The most common. The most common.
think hypoparathyroidism, doctor, or what do you mean?
Hypoparathyroidism.
If it's iatrogenic, it's
Exactly. This is what I
after
mean.
thyroid
Yes,
surgery.
exactly. So this is the most common, and it happens usually with thyroidectomy, total thyroidectomy. So the patient will present with tetany or spasm or weakness, or even severe hypocalcemia might lead to ECG changes, right? So this is the first one. What other cause of hypocalcemia, you know? Our case today, chronic kidney disease, right? Okay, the third is, anyone knows the third one? McAlbright syndrome, pseudo.
Vitamin D deficiency.
Sorry, vitamin D deficiency.
Deficiency.
Yes, and pseudo hypoparathyroidism
Yes,
is
pseudo.
congenital.
Yes,
Yes,
yeah,
yes.
pseudo because it came before. Pseudo hypoparathyroidism. It's congenital anomalies, and you will have the fingers, fourth finger or short fourth finger.
Short fourth and fifth metacarpal.
Yes. So
The pseudo only, Dr.
One
Bassett, that will
pseudo,
have
doctor.
signs of
Yes,
hypocalcemia,
But
not
pseudo,
pseudo
two,
pseudo.
two not
one pseudo.
two.
Oh yeah, one pseudo. Yes, not
Yes,
Yes, one.
two
And
pseudos.
it's not true
Pseudo will be normal.
hypocalcemia.
Yes, you're right.
Not to, yes, it's not true. It is because I think there is, yes, not true. Yes,
Receptors,
the
I think.
problem in the receptors. Yes,
Yeah, but it will present with hypocalcemia, right?
yes, yes.
Oh,
yes,
yeah, Dr. Ayula, I think mentioned the hypovitamin or vitamin D deficiency. So you mean absorption, right? As in celiac? Well, absorption, I
yes.
think, yes. So, but commonly, as we mentioned, the cause I mentioned, it comes in base.
And also in pancreatitis, acute.
Yes, yes, acute pancreatitis. But I think it didn't come in basis as acute pancreatitis as a cause. As
Yeah,
medical cause?
it come
It come?
already.
Really?
Pancreatitis, yes, come and in here already died in Oman center.
As a chronic pancreatitis or as acute
Not
pancreatitis?
chronic, acute pancreatitis. But it's not that bad because acute pancreatitis itself, it had a score.
Yes.
So, yes.
Sorry, doctor, as a case of what came in Oman?
In hyperlipidemia, the patient familiar hyperlipidemia and has acute on top of chronic pancreatitis.
Oh, thank you.
You mean hyperthyroidism?
Yes, I'm not sure exactly because it's one of my friend, but it's case of acute pancreatitis, and she mentioned all the causes. Alcoholic, it can be stone, gallbladder stones, it can be drug, it can be
Get a smash.
yeah, yeah.
But in this case, should be family history of hyperlipidemia.
Yes, they
Mainly
guide here in
triglycerides.
the questions that what you need to ask in the family and
I think I heard about this scenario. Her father or her mother has some stroke or MI.
the problem is
Early.
my friend lost the family history, so she don't know,
Mm.
but they guide here in the questions that something wrong in lipid or something.
And the
Yes.
presentation was abdominal pain?
Yes, abdominal
Yes,
pain.
yes, acute pancreatitis now appearing in UK once, and this is again here.
Yes, because the vision will not that bad, Dr. Bassem, with it has criteria, and after 48 hours they will decide. Maybe he has mild form, not that acute form.
Okay, good to know. Okay, thank you, Dr. Aisha. Anyone with question? Any missed or suggestion? It's good to be interactive session. So whenever anyone has a doubt, raise it, and we will have also feedbacks from other centers, from friend to friend, and it will help. Definitely, it will help. Maybe you will hear one sentence here, and it could be your case in the exam.
Yes.
Even if you will not practice it, but you heard it, like the pancreatitis today, for example, and abdominal pain patient present with, and the familial hyperlipidemia as a family history. So you will remember this case whenever you have it, and you will never forget to ask about family history of stroke or blood clot at early age or sudden death at early age in the family. So it's like this. Whenever you
And the
raise
patient
an
will
issue,
have xanthelasma or tendon xanthelasma or
yes,
around the eye. There will be some features, but yes, it is maybe far away from our yes consideration in pancreatitis, but it should be come to
and
our mind also in
yes,
any
exactly.
case of pancreatitis.
You should consider it. I think corneal arcus
Dr.
as well.
Bassem,
Yes.
sorry, we discussed this case with Dr. Ayola before.
Mhm.
This he came with
Exactly.
epigastric pain with
Yes.
acute pancreatitis, and
Yes.
his
Yes.
father died with age 45.
Yes. We mentioned yes.
Dr. Ayola, yes, we discussed this case, yes,
Yeah.
about
We.
hyperlipidemia. Yes.
I think 2 weeks back. Yes. It was nice case also by Dr. Ayo, and she mentioned all possible cause.
Yes.
We discussed the inheritance also way of either autosomal recessive, but in details, it's very difficult to know the schedule of the types of hypercholesteremia or triglyceridemia and what the medication. It's really difficult and very easy to forget. But at least to know there is familial condition, which is the fat or cholesterol will be high or triglyceridemia, that it can deposit in the pancreas and it will lead to the pancreatitis. And you have to put it as a differential whenever you have a clue of family history and blood clot and even the tendon or eye or fat deposition under the skin. So in this way, you remember the as a
Okay.
cause. Okay, Thank you again, Dr. Al-Huda and Dr. Sarah and Dr. Aisha and everyone attend today. I hope I didn't forget any of you. Anyone with question before ending the session? Any comments?
Thank you. Thank you.
Thank you,
Yes,
Dr. Basim.
Dr. Ayul, right? Okay, thank you. Okay, if no more questions, see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Ah,